So this presentation will aim to explore changes that occur in the lower leg as a result of a leg ulcer diagnosis. Describe Necrobiosis Lipoideca in relation to assessment and management of the condition. Identify the defining features of a skin cancer that can be found on the lower leg. Describe the management of these lesions and explore breaking bad news. So what is a leg ulcer? Well, we all know, we're all from the leg club, and we know what a leg ulcer actually is. A loss of skin below the knee, on the leg or the foot, which actually is longer than 6 weeks in healing. That's the definition of an ulcer rather than a wound. However, how many other wounds take more than this time to heal, or in fact never heal without further intervention? We had one gentleman who'd had his wound for 69 years. He was a guy who was fighting the Vichy French before the Second World War, and he was shot in the legs. The bullet went through the first leg and blew the second leg off, so he had only one leg. And he laid in the trenches all night waiting for somebody to rescue him. And from that time onwards, although he had some excellent care by the Vichy French, they really looked after him at the time, from that time onwards he had a wound that didn't heal. Now, could that be classified as a leg ulcer? The nurses didn't think so, so they didn't treat it as a leg ulcer, they just treated the symptoms. And when he came to the Wound Healing Centre, he was put into compression for the very first time, and his wound healed within 12 weeks. So it's understanding what that definition is, and it remained healed for the further 6 years since then. So it's quite a thing to know what you're actually dealing with. Here go the glasses again. So do we call all of these leg ulcers? The presentation will aim to I just did that, didn't I? Sorry. Right, so is this a leg ulcer? Is this what we would call a venous leg ulcer? Or is there something more going on here? Is there a cancer perhaps that we should be looking at? This is pretty much a venous leg ulcer. So you could tell the difference possibly. That first one is not a natural wound, is it? So the types of ulcers found on the lower leg and feet are venous ulcers, which is about 70 to 80%, arterial ulcers, which is about 10 to 15%. There are mixed etiologies. There are traumatic ulcerations, hematomas, and we do see quite a few hematomas, diabetic wounds, and vasculitic ulcers. There's venous disease. We have the varicose veins, obviously. Pigmentation of the gaiter area. That's a very clear sign. Ankle flare, again, another very clear sign. Skin atrophy, eczematous changes, woody indurated tissue, champagne bottle leg appearance, which we heard about earlier, warm, well-perfused extremities, and palpable pulses. What Heather hasn't got there is pain. Quite often we think arterial ulcers are the only ones that have pain, and those of us that deal with leg ulcers, and you included, will know that pain is a symptom of venous leg ulcers as well. You can have some really bad, painful wounds. Arterial disease, the ulcers are usually punched out like an apple core, and an acute onset, may occur in unusual places. It's not usually around the gaiter necessarily. Surrounding skin is pale and shiny. The leg is often completely white, or sometimes the foot can be a dark sort of reddy colour, and there's no hairs. Patients describe the pain as cramp-like, night pain, rest pain, and claudication, and can have quite a lot of pain on walking, which goes at rest. And then there are weak, thready pulses. When we do examinations in the Wound Healing Centre, we always do sounds. We always recommend to listen to the sounds. We also do a pinch test, which tells us the reflushing time, because reflushing in the toes should be 3 seconds. If it's 7 seconds or more, then you've possibly got some arterial involvement. So we always do that, and we always do oximetry as well. So look at the oxygen levels before you put bandaging on and after, and then you know that the bandages are working well. This is an arterial wound, a gentleman that was in excruciating pain, and we didn't seem to be able to help him at all. We could only treat the symptoms. This is both arterial and from poor bandaging. So this person had bandages on far too tight. And because it was arterial, of course, it did a lot of damage. And with arterial wounds, quite often, you do see those tendons poking out. Again, another arterial wound. It's not on the gaiter area, as you would expect a venous ulcer to be. So what makes you think that the wound on the leg is not a venous or an arterial leg ulcer? The venous disease is excluded. There's appropriate compression, and yet it's still failing to react, to respond. No evidence of varicose veins, and duplex, no incompetent veins on duplex scan, no clinical signs or symptoms. An arterial disease is excluded, and there is a good ABPI. No evidence of arterial disease and no clinical signs and symptoms. And a neuropathic ulcer is an entirely different ballgame. It's usually located on the pressure points underneath the foot, under the bottom of the foot, but you can get it anywhere on the foot. The base is quite often palpable. You can palpate to bone quite often. They're quite nasty. May not get pain with it at all. And obviously, patients are generally diabetic, but not always. We've had a few patients who are not diabetic at all and young and have neuropathic problems. This was a diabetic foot who came to the clinic. You can see how really terrible that was, and they were talking about amputation. And he healed very quickly under the guidance of our podiatrist, our diabetic podiatrist. Another one, this was pretty bad. It was difficult to heal, but you can heal these wounds, but they, are not easy to do. So Necrobiosis Lipoideca. This is an uncommon condition in which the etiology is not well understood. It's an inflammatory condition which is thought to follow damage to the collagen fibers in the skin, and some think it's related to changes in small blood vessels. Most patients with necrobiosis have or will develop diabetes. However, it does not appear to be related to diabetic control. It can occur at any age, across all races, and is 3 times as common in women than in men. The presenting features are shiny, red broken or yellowish patches. They develop in the skin, usually on the shins. Isolated patches initially, which are slow growing, and patches can join together to form irregular shaped lesions with a well-defined red border. Blood vessels are often visible in the yellowish center of the lesion. The skin is often very thin, and the lesions can be very painful. Very prone to trauma, and when ulcerated, the lesions can take a long time to heal. And ulcerated lesions often become sloughy as the layer of the dead tissue becomes separated from the living tissue. So confirming the diagnosis, to an experienced clinician, the lesion presentation and history is enough. A skin biopsy can be taken to confirm the diagnosis, and those of you who send people for biopsies probably know that you can't always diagnose something. For instance, pyoderma gangrenosum can't be diagnosed from a biopsy. It can only be excluded through the biopsy. Testing for diabetes is not already diagnosed. So a case study, this is Heather's case study, 24-year-old with type 2 diabetes, ulcerated areas to her right leg, failure to heal for more than 4 years despite compression bandaging, significant trauma to this leg following a motorbike accident in 2009. And from what I've read about this lady, she's a little bit naughty, I think. Treated as a leg ulcer, moved GP surgeries as no progress, and recurrent knocks to legs from skateboarding, so she's not exactly looking after herself. And presenting features a large purple plaque with a number of punched out lesions, and also had 2 orange, red shiny lesions. And this was her as she presented to Heather. And you can see that's not a normal, natural looking wound, is it? It's something that's completely different. And this Heather managed to turn around. So diagnostic, this was the management plan, diagnostic punch biopsy to confirm diagnosis. Histology showed necrobiosis. An oral prednisolone was given of 60 milligrams a day, and this could be increased to 1 milligram per kilogram if required. Omeprazole, because of the, obviously because of the steroids. Venous duplex scan, diabetes management, topical antimicrobial dressings, short stretch bandages, and monthly review, and telling her to keep off her blooming skateboard. And this was her after the management, and you can see it was still not a natural looking area, and it's going to take a long time to be correct, but the scarring will fade, but it'll never go. It'll always be there. But it looks a lot better than it did. This was the before and after, so that you can get a view of what it was and what it is now. So management options. Treatments work best if the diagnosis is made early. There's no effective cure, but symptoms can be managed. Scarring follows a flare, is usually permanent. Potent topical steroids may be helpful to reduce the spread. And we'll talk a little bit more about topical steroid again in a minute. Oral medication to reduce inflammation, steroid therapy, or an immune suppressive drug such as cyclosporin. PUVA, long-wave UV light, may help certain patients, and advise patients to avoid injury. So what's this wound? This is not a normal-looking wound, is it? It's definitely got that sort of unhealthy look to it. So we're now going to talk about cancers. Skin cancer. Now, I used to be, when I was young, many years ago, before I had any common sense, I used to be a sun worshipper. So I used to lie in the sun. I used to work nights as a nurse and then go and lie in the garden during the day and sleep all day and lay in the sun. And I've done terrible things to my skin. I have awful problems with it and discolorations and so on because of what I did. We know a lot better now, but it's too late for me. I'm far too long in the tooth to do anything about it. So it's one of the most common cancers in the world, with 100,000 cases each year. Melanoma is less common, but spreads faster in the body and is quite a nasty one. And non-melanoma skin cancer is more common. And the first signs are usually the appearance of a lump, often red and firm, or a patch, often flat and scaly on the skin that doesn't heal after a few weeks. Well, I had on my leg, and you'll be horrified because it was before I was a tissue viability nurse, but you'll be horrified at me. I had on my leg what I thought was a wart. And I had a friend who was a beautician, and he said, I can get rid of that for you, no problem. So he got one of those electrodes, and he put it down underneath the wart. It hurt like hell. I have to say, it's one of the worst things I've ever had done. It really hurt. But he put it down under and he got rid of this wart. But a few weeks later, it had come back again. And I knew then that there was something wrong. I mean, a wart wouldn't grow that fast. It was itchy. I mean, if I had it now, I'd know that there was a problem. It was itchy, it was sore, and I was always conscious of it. And I had a consultant who was a vascular consultant who was also a friend, and he said, oh, I'll deal with that for you. And he cut it out and sent it away, and it was a Bowen's cancer. So I was really lucky because he said it was still contained, and if it had come out of its shell, you know, it could have spread. And doing that sort of electrodes could have caused so much problem, but you don't know at the time. And since then, in my face, I have a lot of these actinic keratosis. I have a lot of them. And the first one lasted about 2 years. So I went to a skin clinic and had it examined and had the diagnosis. And since then, I've had a lot. But because I work in a clinic, I just get the nurses to cut it out for me. So we have some little biopsy things that we just nick them out, and they go quite easily. I've also found personally that tea tree helps things like that. If you put tea tree naturally onto skin tags or you know, this keratosis, it tends to remove it. So etiology, a non-melanoma skin cancer usually develops in the epidermis and are named after the type of skin cell from which they develop. Basal cell carcinomas, 75%. Squamous cell carcinomas are 20%. Caused by overexposure to UV light. Risks are increased by family history. Pale skin, large numbers of moles or freckles. And precancerous lesions such as, I can't say that word, actinic keratosis or Bowen's disease can sometimes develop into squamous cell carcinomas. So I was really lucky that I got it sorted out before something like that happened. But you do need to look at these little warts on people's legs and wonder, you know, does it itch? Has it got any redness around it? Is it an unusual thing? Is it growing quickly? And get it sorted, you know, make sure that before it turns into something really nasty that it is sorted. This is, and I can't say the word, I'll just say keratosis. I cannot say actinic keratosis. This can go on for 2 years being open before it turns into anything else and needs to be sorted. This lady obviously has patches all over her legs. She's obviously had her legs exposed to sun. So finding a diagnosis, it's important to get a full clinical history, identify the length of time the lesion has been present and how it first presented. Look at what interventions have been provided and what effect they've had on the wound size. As far as how long the lesion's been there, that lady with lesions on her legs probably has had that for more than a year without it healing before she actually got to see somebody. So it's important that people know that they have to get these things sorted fairly quickly. Look at the site. Is it an unusual place on the lower limb? Are there multiple lesions like there are in that lady? Has the patient had anything like this in the past? Another thing you looked for in a wound is rolled edges, cauliflower type edges to a wound, or the wound itself looking like cauliflower. Quite often that is cancerous. So a wound that's been there for a long, long time can turn cancerous anyway, so we have to be really careful because we're not going to heal that very easily. So diagnosis, if you suspect a skin cancer, a referral to a dermatologist or a local GP provider for a skin biopsy. Squamous cell carcinomas are more urgent within 2 weeks, whilst basal cell carcinomas can be seen within 18 weeks. I've actually seen, and I'm sure some of you have, a basal cell carcinoma where it's been near the eye and the lady didn't know that she had to do something about it, and it actually ate away the whole of her eye and ate right back behind her nose and was going into the other eye. And she was dementing a little bit. I think I probably would be if I had that. And she was in the ward and she would not wear a dressing. And she wanted to walk around the ward all the time with this great big hole in her head. It was just awful for the other patients. Histology will confirm the diagnosis. And a plan for ongoing management will then be put into place depending on the size of the lesion. Surgical management. Well, surgery involves removing the cancerous area of the skin. For a low-risk, well-differentiated squamous cell carcinoma, 4 mm margin, and a high-risk or moderate or poorly differentiated squamous cell carcinoma of 6 mm. As there is a low risk of spread, less than 0.5% for basal cell carcinomas, and 2.5% for, or 2 to 5% for squamous cell carcinomas, systemic treatments are usually not required. Treatment for non-melanoma skin cancer is completely successful in 90% of cases. In some patients, however, there's a risk that the skin cancer will return. However, this is more common in patients with melanoma. And I have to say my Bowen's has never returned, and that was dealt with about 15, 20 years ago. So, you know, it can be removed and be gone. This is obviously quite a nasty case. It looks like there are several areas, and I think the surgeon has marked out exactly what part of the skin he's got to cut out. Now, if he had got to that sooner, maybe just a little nick would have got rid of the whole thing. So, are you allergic to anything? I mean, aside from anything that's already bit you. We need to know that bites also can turn very nasty. We've seen some terrible bites from America on legs where you get the brown recluse bite them when they're in bed. The brown recluse spider crawls up inside the covers, bites the leg, and you end up with this massive black area which is really, really hard to deal with and generally turns infected. And I'm sure Gary can tell horror stories of spiders that they see in Australia and having to deal with things like that. We don't see so much here, but we are seeing more now of spider bites. And are they classified as a leg ulcer? Well, certainly they will be if they're there for longer than 6 weeks, because, you know, that's how we classify an ulcer, isn't it? Anyway, thank you very much for listening to me. I hope that I didn't stumble too much over her presentation, and I hope it got some justice for her, bless her, because she's so unwell at the moment. Thank you very much for listening.